Thank you. Thank you for having me. You can see the title here, and as you can see at the bottom of this slide, I've been on a journey. I started here a long time as a medical student, but I've been fortunate to work in many different places, both in Europe, University of Padua, different places in the US, back to Uppsala 14 years ago, and been here now for 2 years. And I'm going to talk about something that's close to my heart. It's about muscle wasting and muscle paralysis that is acquired in intensive care unit patients. But before I start about that, I'll tell you a little bit about the background. So this is of the two disease entities that we're specifically interested in: critical illness myopathy and ventilator-induced diaphragm dysfunction. I'll tell you a little bit more why we think it's important, because it has significant consequences for patient mortality, morbidity, but also for financial reasons for healthcare providers. And we sort of stand on 3 different legs. We try to understand mechanism, try to improve diagnosis and monitoring, and what we major focus right now is to introduce different intervention strategies. But before we go into this, I would talk a little bit about muscle as well. Of course, this is basic knowledge that you all know about, but skeletal muscle is tissue that has been oversimplified for so long, really. It's not only an organ that generates force and movement, it has so many other functions as well, really. It's an energy store for during starvation, intensive care, etc., involved in thermoregulation. It's a passive mechanical protection against viscera and bone, but it's also producer of many growth hormones and cytokines that has autocrine, paracrine, and endocrine effects, so to say. And this probably has many other effects as well. And there's no muscle that is the other one alike. And it's not only about being fast or slow. These muscles are unique, so to say. And they're different embryological origins, as we'll talk about later. Craniofacial muscles have a completely different embryological origins than trunk and limb muscles. They stem from the branchial arch, same as the heart, while the others stem from the somatic stem. And it has an impact on the structure and function of these muscles, although they are striated, so to say. And it also has a strong impact on this muscle paralysis that we talk about in intensive care unit patients. And of course, the dominant protein in skeletal muscle is myosin. It's the mechanoenzyme that converts chemical energy during ATP hydrolysis into mechanical work. And myosin is expressed in all cells in the human body. And I think when this slide was made, there were 18 different classes. The class we are interested in muscle is class 2. And it's the myosin that polymerizes into these 2-headed myosin filaments that makes up the backbone of the A band in the sarcomere. I will come back to that later, because you know the final functional unit in the muscle is the sarcomere. 2 C lines, and in the center we have the A band, and that's where they have the motor protein, which is also called the myosin band. And it's sort of, for me, it's a sort of a love story with this organ. I started with this as a graduate student in the early 70s. And I can tell you, I think it's been a fascinating story. It's a beautiful tissue to work with, and it's catching the moment, so to say, to see a single muscle cell contracting and try to understand mechanisms regulating contraction, etc. I started out in a very simple fashion, tried to look on in vivo muscle function, how to relate to muscle structure, biochemistry, but I think you can find myriads of associations, but you can't really understand basic underlying mechanisms. So then we moved into an experimental animal model. We characterized the spatial organization of motor unit fibers, the muscle cells innervated by single motor axon, by using a technique called the glycogen depletion technique. And this was also driven by interest at that time to understand the mechanisms underlying the aging-related motor handicap. And then we could sort of characterize the muscle cells innervated by single alpha motor neurons as glycogen depleted, as the white ones here. It's the only method we don't have set up right now. But I also do clinical duties 1 day a week, and then we use electrophysiological techniques to characterize the motor unit in patients with neuromuscular disorders. But where we had a major focus is try to understand regulation muscle contraction at the muscle cell level and scale it down to the small cell segments we obtain with the percutaneous muscle biopsy technique, which is a very small intervention, take out a small piece, you treat the muscle cells, membrane permeabilize them, I'll show a little bit later. But we also set up a specific method where we can extract myosin from a single cell, look at the catalytic properties of the myosin molecule and also its force generating capacity. And then we've been fortunate to work with various skill groups. We can also look on mice and structure, mice and modifications, primarily with mass spectrometry, but also with these X-ray diffraction experiments with Spring 8 in Japan. And of course also looking at gene expression. I mean, I'm not a molecular biologist. I see it mostly as techniques we can all use, as long as we understand weakness and strengths with these techniques. And I'll come back to that as well. And I always want to talk about, I had many different mentors. And I always want to stress Giovanni Salviati, who introduced me to this skin fiber preparation. And working in Padua, Italy. At that time, we were trying to understand in rodent muscle cells calcium handling by the sarcoplasmic reticulum. But Giovanni was also working with human muscle cells. We took open biopsies and they looked on caffeine sensitivity, tried to detect carriers with this malignant hypothermia. And I thought maybe this could be a way to come back and study regulation of human muscle contraction under controlled conditions, without the secondary influences of central components, bone joints, gravity, etc. But I was always trained to work with small muscle tissues, not open biopsies. And what we did, Giovanni had this method. He had a sort of method where you membrane permeabilize muscle cells. So you break down the muscle membrane, you kill the muscle cells, you kill the mitochondria and so on, but contractile machinery is still there though. So the contractile proteins, remember C-line, A-band, where they have the myosin, which means we can then bypass excitation, contraction, coupling, and activate the muscle cell directly, which was triggers the muscle contract, which is calcium. And also, I told Giovanni I didn't want to work with open biopsies. I've been told it's unethical, which is probably not true. But I mean, because in small children, if you do an open biopsy, you also have to do it in general anesthesia, more or less. And anesthesia is always as a risk factor, and especially in patients with neuromuscular disorders. So he told me, go to Rick Moss' lab. He has set up a technique to attach short muscle cell segments. And I went there, worked on a different protein, but I had my side project. It was as to trying to also understand regulation of human muscle contraction. In the small pieces we get with the percutaneous muscle biopsy, we can then attach a single cell. This one is just 1.3 millimeters between the connectors. And they're sitting here, one end attached to servomotor, on the other end to force transducer. And from a biopsy like this, you can get 800 muscle cell segments if you want to. You can work for a year with a biopsy, so, which probably don't want to do. But anyway, we can characterize then the contractile properties of single muscle cells, see how it is related to the myosin isoform expression, etc. And later on, as I said, we developed this in vitro motility assay because we want to look on myosin function without secondary influences from structural proteins, etc. So then, by setting up a method together with a group at King's College London, we have your muscle cell, we put it between two streaks of grease on a slide, and then on top we put a cover slip. So in high salt solution, we extract myosin for about 20 minutes, and then you flush the cell in low salt solution, and you hope that myosin will stick to the floor and the ceiling. And then later on, so here you have the muscle cell, this is the myosin streak, and then you block deadheads that are non-functional, that go in Rigor instead. And then you add fluorescently labeled actin filaments. And when you add ATP, myosin will start propelling these actin filaments. And here you see these actin filaments, the white spots, moving in two directions. It's organized motility. Then we can measure the speed by which these myosin filaments are moving, which is a molecular analog of maximum velocity unloaded shortening. And then by adding my actin binding protein and increasing concentrations, alpha-actinin in this case, the number of moving filaments will decrease. But the stronger the protein, the more filaments will be moving. So then with the increasing alpha-actinin concentration, the slope of this curve is an indicator of the force generated by the myosin molecule, or this isoform that we have extracted. The steeper the slope, the weaker the protein. So, and typically, or often, muscle wasting is considered to be a homogeneous entity, but it is as heterogeneous as you can imagine, really, and it's specific with each condition. And this is something where big pharma often, they don't understand this really. They think just blow up the muscle in size, you solve the problem. In my mind, that's not the way to think really. You should go for the mechanism and try to intervene with the mechanism rather than just blowing muscle size up, blowing this muscle up in size. And we are particularly interested in this weakness associated with critical illness in intensive care unit patients. And as you may know, we're moving from an old hospital to a new one. And in modern hospitals, the total beds in hospitals are decreasing in number for several reasons. One of the major reasons is a much faster turnover. But what is increasing is the number of intensive care unit beds, because intensive care has improved dramatically over the past decades for several reasons, both better methodology, better knowledge, but not the least introducing evidence-based medicine into intensive care and removing interventions that have been more harmful to the patient than helpful, really. And this has improved survival. But with improved survival also comes consequences of modern critical care. And that's what I would like to talk about today, though. And this is a disease that was described the first time in the Lancet, a short report. A young woman came to the emergency room with a status asthmaticus attack. She could not be cured with conventional treatment, so she was transferred to the intensive care. There she was given massive doses of corticosteroids to fight the infection, but also to ensure oxygenation of the central nervous system. She was hooked up with a ventilator. At that time, neuromuscular blockers were frequently used, so the patient would paralyze pharmacologically, so she would not work against the ventilator. When the infection was cured after 1 week, it was found that she was quadriplegic from here on down. She couldn't move any limb. She had intact cognitive function, intact sensory function. And then the good thing in this story, though, this woman, young woman, she survived, and she recovered almost completely, but it took several months. And then this was considered to be a rare condition of limited clinical significance. Now we know this is the most common cause of acquired paralysis in the intensive care. 30% of patients that are on the ventilator for longer than a week develop this paralysis. And some subpopulation, is 100% that develop this paralysis. By accident, I heard about this when George Capote, who at that time was the head of the Montreal Neurological Center, he came to Karolinska Hospital, where I was just setting up the skin fiber preparation. He came into the room, he said, wow, this would have been a perfect technique to study the patient I just saw. And he described a patient like this. And he did something no one else had done before. He took a muscle biopsy, he did electron microscopy. And he saw the C band, but no A band in between, no motor protein, so it's not so surprising the patient was paralyzed. And these patients have in the past been misdiagnosed as neuropathies. But I was on call Christmas '95, and a neurologist at St. Göran's Hospital, he had this strange patient that developed quadriplegia, an elderly woman. And he's a very serious neurologist. He had examined this patient carefully, did this CT scan of the brain, normal, MRI of the brainstem, normal, take the fluid from the spinal fluid, and typically when you have this acquired neuropathy called Guillain-Barré polyneuropathy, you have a protein peak. There was no protein peak. So he wanted me to go over and do our electrophysiological tricks then, and it indicated actual motor axonopathy. But at least I remember this, what George Capote told me many years before, so I took a muscle biopsy as well. And here you see a muscle cell from a controlled person under relaxing, maximum activating condition, and this is from the patient. And it doesn't take a trained eye to see something is wrong here. And we take these, and these cells didn't develop any force upon maximum activation either. And typically, after we've done this, we solubilize the fiber, look at the myosin isoform expression on a gel. And these are the 3 myosin heavy chain isoforms expressed in normal human muscle, a slow isoform and 2 fast. From the patient, we saw no myosin in the single cells, but these are atrophic fibers as well. We loaded up bundles with 10 to 20 fibers. Still, we see no myosin heavy chain. And then we looked in a different gel system, and 1, 2, 3 here is it from a patient with a hemiplegia, one-sided paralysis due to a central lesion. And both on the paretic and the non-paretic side, there's a full expression of thick filament protein, myosin and myosin-associated proteins. But from the patient, no myosin. But thin filament protein like actin and regulatory proteins, troponins and tropomyosin were fully expressed. So there's a preferential loss of myosin then in this disease. And this is something we use as a diagnostic marker today. Once again, control, C-line, C-line, M-band, patient C-band, C-line, C-line, no M-band. And why have they been misdiagnosed? Because using normal electrophysiology that we use on a daily basis in the clinic, We look on motor nerve conduction velocities. You stimulate the motor nerve distally, and you get an EMG response. And you stimulate more proximally, you get another one. And then you can calculate then the conduction velocity over this segment. If you have axonal degeneration, like this, you have loose neurons, you stimulate down there, then you get quite a small action potential or motor compound muscle action potential. Should be like that, stimulate proximally. You also get a small potential then, of course. But the conduction velocity is normal. And this is what you see in these patients. If you can get the compound muscle action potential, conduction velocity is almost normal, or you get no response at all. And then it's easy to misinterpret this as a motor axonopathy. And then also what we do, we put a needle in the muscle, and we record spontaneous EMG activity. And muscle cells that have lost nerve contact, they start to discharge spontaneously about 3 weeks after loss of nerve interaction, since they've been denervated. So then, and sometimes this is also called acute denervation electrical activity. So then you have motor axonopathy, denervation activity, and then you put your foot in the trap immediately, and they say this is motor axonopathy. But actually the reason for the spontaneous activity in this disease is that you have a muscle membrane defect that generates these spontaneous discharges. And this is also why we have a less excitable muscle membrane, and that's why we get the low compound muscle action potential. So this, and then just by following, after we found the first patient, but just looking around in Stockholm area, we found 10 patients in no time. And now I see almost 1 patient a week, and that's an underestimation of what is in the hospital, I would say. The good thing, though, they recover. Proteins are re-expressed, castration comes back, and force comes back as well. The problem, though, if you want to understand mechanisms, to try to do so in an ICU population, I think is almost impossible. It's such a heterogeneous population, different underlying diseases, polypharmacy, gender, etc. So I think it was very important to go into an experimental animal model. So after finding the first patient, we went into a porcine or a pig model. And I was very fortunate to work with a group of very enthusiastic anesthesiologists here. And so we went down, we packed the car, we drove down to Linköping, where the Army had their pig ICU. I mean, Army physicians, I mean, at least when I went at your age, I had to go do Army service every summer. And then they sort of shoot pigs and you practice on those. So that they have this pig ICU there. And the interesting thing, so we put 4 pigs in the ventilator, exposed them what was considered to be the triggering factors, corticosteroids, sepsis, and neuromuscular blockers. 3 out of 4 pigs died the first day, but 1 pig survived for 5 days. And that was a world record, I can tell you, to keep a septic pig alive. And that's not because of me, but because of these very skilled anesthesiologists. And the interesting thing, this pig on day 5 showed an electrophysiological picture similar to what we see in these ICU patients. So we thought this may be a good model then. Then we moved away from this country, we thought forever, but we came back after 5 years, and then they have set up the model here at Karolinska Hospital. So then we did a series of experiments where we exposed the pigs to these triggering factors, mechanical ventilation, and sedation. And one group also got blockers, one got corticosteroids, and one got sepsis, and one got all combined. In 5 days, we don't see muscle atrophy. And in these 2 groups, we don't see really loss in force either. But when you did gene array experiments, 1,475 genes went up, significantly up or down. And that may sound a little bit strange to you, or it did to me at least at that time. But, of course, there are also protective mechanisms. There's a reason why a hibernating bear comes up in the spring with almost full muscle function, or that you wake after long night sleep, you don't wake up with muscle atrophy. So then when we compare this group, where there's the dramatic loss in force generating capacity, what we call specific force, which is maximum force normalized to fiber cross-section area, is down to almost half. Then we can try to understand which are the differences here. And what was consistent finding, when size and force was maintained, heat shock proteins were upregulated. As I mentioned before, craniofacial muscles were typically spared. And when we look in pigs that have been exposed to blockers, corticosteroids, sepsis for 5 days, in the craniofacial muscle, size and force generating capacity was intact. But in the limb muscles, force generating capacity was down to almost half, independent of cell type. And once again, the difference was heat shock proteins were upregulated in the craniofacial muscles. There were other differences as well, of course. So at least this was something in the background of mind, is maybe this could be an intervention strategy. I will come back to that at the end of the presentation. The diaphragm, though, is completely different. The open bars here are from control cells, and these are the different myosin isoforms, and the different colors here are the different groups, sepsis, etc. Here, the common denominator is mechanical ventilation per se. No difference if you add blockers, sepsis, whatever. And this is a different type of muscle paralysis that you see in the respiratory muscle than in the limb muscles. And I'll try to come back to the mechanism here as well. The problem here, in 5 days, we don't get the phenotype that we see in intensive care unit patients. We don't see the preferential myosin loss. We don't see this in ICU patients either in the first week. It comes later. When I worked in the US, I was fortunate to work with Barry Dworkin, who had set up a rodent model to try to understand regulation of blood pressure. And he had developed a ventilator where you can keep a rat on a ventilator for long durations. His record is 97 days, pharmacologically paralyzed mechanical ventilator rat. If you buy a commercially available ventilator, you can keep a rat alive for maybe 24 hours, then they're dead. So long-term experiments looking on ventilator-induced effects on the diaphragm are typically long-term 18 hours, not telling that the rat is dead after 24 hours, so to say. So there is a confounding factor. So I thought this could be a very good model for us to try to understand mechanisms in a time-resolved fashion then. And these rats, they develop the phenotype that we see in patients as well. We see a preferential myosin loss, dramatic loss in force generating capacity. Also, and we have a preferential myosin loss, filled bars myosin, open bars actin. Myosin goes down, but not actin, independent if it's a fast or slow twitch muscle, limb muscle. Massive transcriptional downregulation, the same thing as we see in patients. Activation of different proteolytic pathways. So what is then the mechanism here? And these are not giving corticosteroids, they're giving the blockers, but as we can see in the pigs, blockers really doesn't do anything additional to just complete immobilization and deep sedation. What we think is a very important factor that we have in these ICU patients, which we don't see in any other muscle wasting condition, is what we call complete mechanical silencing. No weight bearing, no internal strain related to activation of contractile proteins. And all cells are sensitive to mechanical strain, and muscle cells are extremely sensitive to mechanical strain. And there are mechanosensors all the way from the outside of the muscle cell, integrins that connect to structure proteins in the subcirculemma, structure proteins that bind directly to the nucleus, sending a mechanical strain, structure protein binding directly to mitochondria. We have mechanosensors in intermediate filaments, we have mechanosensors in the C-line, and we have mechanosensor in the center of the C-line in the M-band. And this is just sort of an anecdotal finding, which is a very sad one, really. It's a young boy, 6 years old, waiting for a lung transplant. He was giving massive doses, and he was on the ventilator. And this is, unfortunately, a post-mortem biopsy because he didn't survive. And actually, so this is after, so here you can see, you know this sensory organ, muscle spindle. It's the organ that senses length changes and speed changes in muscle. And then there's a small group of muscle cells, intrafusal fibers, that are under constant tension with the gamma motor neurons. But if you look at extrafusal fibers here, these are extremely small, smaller than intrafusal fibers. And extrafusal fibers are typically larger than the whole spindle. And the difference, again, mechanical strain. It's not proof, but I think it's an interesting finding then. So at least what we did then, we did a very simple experiment, just put one ankle joint in a servomotor driving and one ankle joint, keeping the other leg completely immobilized. And then after 2 weeks, now we don't have the 2-week point, we reduced muscle wasting by 20%. And also reduced the muscle wasting at the cellular level and also reduced the loss in specific force. And we did the same thing in ICU patients. Monica sitting here was an active part in that project and actually doing the same thing. I think it was 10 hours doing this servomotor driving in one ankle joint. It didn't increase the size, but it improved force generating capacity. So what is this then? Well, this is physical therapy. So I think what is the take-home message is Early physical therapy is very important in the ICU patients. Just move the limbs and get this mechanical strain. And the mechanism, here I'm running short of time here, so there are different mechanisms. It affects protein degradation pathways, it affects mitochondria, it affects apoptotic pathways, and apoptosis and signaling. But I would like to talk before we end up also a little bit about the diaphragm. And because you see, the costs in ICUs are enormous really. And one of the major triggering of these costs are mechanical ventilation and the slow weaning from the ventilator. More than 30% of the time in the ventilator is due to just prolonged weaning. And then there's a group, getting the patient out of the ventilator because they can't breathe spontaneously. Mainly because of an impaired diaphragm muscle function. And then there's a small group of patients that stay on the ventilator for weeks or months actually. And these patients are predicted to cost by 2020 $64 billion annually in the US. Healthcare cost in the US is 16% of GDP. In Europe it's about 8%, so here's about, well, it should be, sorry. This should be 34 and this should be 64. Anyway, it's a lot of money. So what are the mechanisms? Here's completely different. We don't have a preferential myosin loss, but we have protein modifications. Post-translation modifications of myosin, which we have measured in different ways then. And this is we're coming back to these heat shock proteins. So we have tried a class of a pharmacological agent called chaperone co-inducers that upregulate heat shock proteins. Heat shock protein 70 in particular. It inhibits this PARP1 pathway, and this is a membrane stabilizer. It also affects mitochondria. It's a drug that developed primarily to type 2 diabetes. But we have tested this in this rat model. So red here is 10 days mechanical ventilation without this chaperone co-inducer, which is called BGP-15. Doesn't really affect muscle size after 10 days, but it improves force generating capacity by 100%. So what are the mechanisms here? You remember this one? So we can then pull out myosin, and we could then see, when we compare the force generating capacity, when you give this BGP-15, it protects myosin from protein modifications. And there are a number of different modifications. One modification we looked at sumoylation. This is without the drug, this is with the drug, but there are also a number of other modifications, of course, that we have identified with mass spectrometry, which the protein is protected from. But there are other proteins that are not protected. Some are not, and this is just doing Raman spectroscopy on muscle tissue from this. So just wrapping up now. So this is where we are at the moment. So we're now testing different pharmacological intervention strategies with the goal of translating them into the clinic. And also improve diagnostics. So we scale the biopsy down, so we have this disposable needle. So just when I go to the clinic, take out 5 milligrams, and that's enough for diagnosis. We can even use it for monitoring. And the two factors that most strongly predict mortality and morbidity in ICUs are old age and muscle wasting, and they are of course interrelated as well. So this is something we are going after as well. And I will just show you one picture of this, and this is almost the last one. Here we have tested the effects of mechanical ventilation in young and old rats. In 5 days, we don't see very much happening, as you remember. So this is a young control, 5 days, and this is the, this is the relative expression of a cytokine, IL-6, in adipose tissue. In old age, we have this low-grade inflammation, so the cytokine levels are slightly elevated, but with mechanical ventilation, they go up dramatically. But with BGP-15 intervention, it's restored. And now we look in limb muscle, not in diaphragm. Phil Bar is young. We don't see much change in any of these interventions, but in the old, it goes down dramatically because it's an exacerbation of this low-grade inflammation, but with the BGP-15, it's almost restored. And there are many other cytokines that are involved as well that we see are upregulated during these ICU interventions. And there are specific interventions where you can target these as well. And this, of course, we don't do this on our own. I'm very fortunate to have a very good group. Unfortunately, Monica has been in the group, now coming back, and I don't have your picture here yet, but it will be back there again. So. And of course, we have many friends worldwide, so we work more with people outside than within Sweden. And thank you for your attention.